I think we're up and live here. I want to welcome everyone as people continue to filter in. Do we have everybody online or anybody still in the waiting room? Can I get a
There,
thumbs up if we're all here? Great.
Yes.
All right, perfect. Well, listen, I'd like to welcome everybody on behalf of the ASES and PrecisionOS. I'm Grant Garrigues. I'm the chair of the ASCS VR Technology Task Force. We have an incredible event tonight. We have some very special guests. I know we have a lot of people joining from overseas. This is our very first international ASCS VR event, and we are so pleased to welcome the group here tonight. So I'll just give some quick introductions and we'll get right into it. Again, I'm Grant Garrigues. I'm a shoulder surgeon in Chicago. And I also want to introduce Danny Gohl. Danny is the founder and CEO of PrecisionOS, also an ASCS member, also a practicing shoulder surgeon in Vancouver, British Columbia, in Canada. We also have Ivan Wong with us. Danny is going to introduce Ivan. We're very pleased to have Ivan with us all the way from Halifax, Nova Scotia. And then all the way from, again, more of this international flair here, Ashish Babhulkar, orthopedic surgeon and shoulder specialist. So Ashish, you can see, is a leading orthopedic surgeon based in Dinanath Mangeshkar Hospital in Pune, India. He's done training internationally with fellowships in the UK, Germany, Japan, and the United States. An absolute pioneer in shoulder surgery. Actually performed India's first ever reverse total shoulder replacement all the way back in 2010, and has been a leader not just in India but internationally in arthroscopic, complex arthroscopic, as well as open reconstructive shoulder procedures. He's the founder and president of the Shoulder Society of India and serves on multiple editorial boards, as multiple publications, and again is a widely recognized thought leader. I first met Ashish when he invited myself and one of our next speakers to be at the first Indo-US shoulder arthroplasty course in Pune in 2025, and that was a fabulous time, and I consider him a personal friend. So Ashish, welcome. We also have joining us tonight, also part of that group that traveled to India for that first course, Samir Nagda. So Samir is a highly acclaimed shoulder and elbow surgeon, chief of shoulder and elbow surgery at Inova Healthcare in Northern Virginia in the DC area. He's an assistant professor of clinical orthopedics at Georgetown University School of Medicine. He's been at some of the finest shoulder training programs, including University of Pennsylvania, and then the Curl and Jobe Orthopedic Clinic. So he's got East Coast and West Coast DNA in him. He's a two-time recipient of the NEAR Award from the ASES for Best Clinical Shoulder Paper, multiple peer-reviewed articles. And in addition to his education, academic leadership, he's really a leader as a team physician. So he's been part of the 2019 Women's World Cup championship medical staff, also Washington Nationals MLB baseball team physician for nearly a decade, multiple other sports medicine coverages, including when he was in Las Vegas, et cetera, et cetera. Long story that Dr. Nagda, also a very dear friend, founding member of the Indian American Shoulder Society, a dear friend, and someone who inspired me to go into shoulder surgery. So listen, I don't want to make this all about the introductions, but we have an incredible group tonight. And I also want to say we have, last but not least, Jay Levin. So Jay has done a lot of work on this. Jay was a Duke resident and then did Rothman Fellowship and is going back to Duke as faculty. They're very lucky to have him there. He's going to do a fantastic job, and you'll see Jay in the virtual environment. So again, we have a lot to discuss. As we get into this, I want to invite you to make sure you put your questions in the chat. My job will be to make sure that those get to Ashish, Samir, and Jay in the virtual environment. So again, I promised a short introduction. I feel I've already overstepped that. Danny, I'll hand it over to you to introduce Ivan, please.
Yeah, thanks, Grant, and thanks everybody for joining. It's my pleasure to introduce Ivan. And before I do that, one of the things that we're really honored to be a part of is the American Shoulder Elbow Surgeons, who have embraced this technology that you're going to see here with the expert surgeons from around the continent and around the world actually today. And before we do that, Dr. Ivan Wong he was a co-resident with me. We were graduated around the same time, and Ivan, many of you know, he doesn't need an introduction, but I will introduce him because he's accomplished so much in his career. So Dr. Wong is a professor of orthopedic surgery and cross-appointed to the School of Health and Human Performance, School of Physiotherapy, and Biomedical Engineering at Dalhousie, where he co-directs the Joint Preservation Sports Medicine Arthroscopy Fellowship. He received his master's in academic medicine from University of Southern California and completed his fellowship with one of the most prominent shoulder surgeons in the world, Dr. Stephen Snyder, at the SCOE Institute. He's also certified as a fellow with the American Board, as well as with the Canadian Academy of Sports and Exercise Medicine. He is also was the past president of the Arthroscopy Association of Canada, in addition to being a board member of ANA, which is the Arthroscopy Association of North America. He serves on the editorial board of multiple journals, including the AJSM, Arthroscopy, the Journal of Arthroscopic and Related Surgeries, as well as the associate editor of the Orthopedic Journal. In Halifax, Dr. Wong specialized in hip and shoulder arthroscopy, including the arthroscopic techniques he's going to talk about today, and reconstruction of large rotator cuff tears and bone block procedures, as mentioned. Ivan is a prolific educator as well. He's devoted his career to his patients, constantly striving to innovate in making procedures less invasive, with smaller incisions, less pain, and shorter downtime. And we're really excited to have him here. He's not only a prolific educator, he's published over 170 peer-reviewed papers, and he's presented his research and techniques at over 200 conferences and webinars around the world. So Ivan, I pass to you to share your screen and educate all of us on your techniques on anatomic glenoid reconstruction.
Thanks, Danny. Thank you and your team, obviously, with ASES PrecisionOS there, to be able to do something like this. So this is super exciting. I get to start off the show, I guess, with a didactic. We'll talk about arthroscopic anatomic glenoid reconstruction and how I address glenoid bone loss. So my disclosures, and hopefully by the end of this presentation here, you'll be better able to understand the tips and tricks of doing an AAGR with distal tibial allograft, and perhaps why the AAGR can be as stable as the latter J, and how it can be as safe as an arthroscopic Bankart repair. So let's go over tips and tricks, because that's what lots of people want to do. So tip number one is we really need an accurate way to measure pre-op glenoid bone loss. I think that was what I was missing for a long time, and it's only over the past few years that we've come back to focus on this. And this is a great thing for one of the sessions that we're doing now is how do you measure the glenoid? And for all this time, we talk about the PICO or perfect circle method, and it's really tough to consistently get a round circle for multiple surgeons to measure. So we made this, we published this paper in 2023 showing the relationship between the superior inferior to anterior posterior dimension. And in short, instead of a long formula, it's really 78% of the height in our Nova Scotia population. So that's really nice, because by doing this, we can actually figure out, compare this to a normal size. And in this case, from the injured side to normal size, you can actually see that it is roughly 78%. So once you have that bone loss established, we now can be able to talk about how we recreate the glenoid. So tip trick number two is the Halifax portal. So AAGR uses a Halifax portal, which does not damage the subscapularis. And this is why we really talk about this in terms of this type of a presentation. So latter J, you're going to hear about in that 3D environment that we're going to have with PrecisionOS. Is really the gold standard. So everything we're going to compare to that, we're going to discuss this more. It's really for shoulder instability with bone loss, and the benefit is that it has a low recurrent instability rate. The problem with it, though, is most of the time, except for arthroscopically, you got to do an open incision. And when you do a latter J, all the anatomy changes. So this is actually a video of one of my colleagues trying to revise a latter J that has progressed onto arthritis, and it's one of the most difficult approaches to go since all the nerve is scarred down. So for all the good stuff about latter J being gold standard, it is non-anatomic. It does use its own bones, so the coracoid does limit. You have to change the orientation of it to make it recreate certain large amounts of bone loss. The subscap is violated no matter how we do it, whether it's a split or a takedown. The nerve is always in play to be injured because it's in your field, whether you see it or not. And progression of arthritis, which obviously will happen in some percentage of the patient, will make future surgeries more difficult. So something that's more ideal, we think, is something that's arthroscopic, anatomic, has a low complication rate, preserves the subscap, addresses the bone loss, and able to repair a Bankart on top of it. So we published our first technique in 2015 that shows a no subscap split. And how that really works is we depress the subscap with all the releases as opposed to cutting or splitting the subscap. And by depressing the subscap, it allows you to get a direct shot. And here you can see the graft insertion from the outside point of view through that Halifax portal, straight into the glenoid through the rotator interval without damaging the subscap whatsoever. And this view allows you to place it exactly where you want. And we've actually done this with Pete Chalmers to be able to show that if you just do this split and use the Halifax portal, the subscap muscle volume does not change from pre to post-op. So it's really nice to see. And that these patients, after we can reconstruct the glenoid, has sustained improvements for at least now a minimum of 5 years. And we're looking even longer than that with patients that have shoulder instability with bone loss. So tip trick number 3, bone resorbs, no matter how you do it. So this is probably our paper that we published in 2020 that kind of scared people off, that said, look, allograft may not be the right thing. So we present our outcomes. Our outcomes were excellent. We're really having no recurrent instability. Resorption happened about 27%, but we had about 13.6% of our patients that had more than 50% resorption, such as this picture right here. And people are wondering, wow, this is a big problem. So AAGR, hopefully that we showed, can recreate any amount of bone loss. We can take a distal tibia and make any shape you want. So that's good and bad, because you can make it supersized glenoid, and that's what we were doing, so shoulders will never dislocate. But 6 years after you make a supersized glenoid, you can see, remember these measurements from earlier on in the talk here, we think that normal size should be 24 millimeters. After 6 years, after we put the graft on, it has remodeled back to 24.3 millimeters. But we made a humongous glenoid for this amount of bone loss. Even though they're not unstable, the screws were irritating. So how do we know how to get the bone model back? Well, we actually looked at our data before. So we've changed our way to do this, and we actually size our glenoids now. We use holograms to try to do this, to recreate the normal size of the glenoid, which is why figuring out exactly how big a glenoid should be is super important. So our first generation technique was making a supersized glenoid. Now that we know how it remodels, we make it to adapt to the anatomic size glenoid. So we're actually trying to replicate the same size glenoid, maybe just 1 to 2 millimeters larger, not a lot larger than that. And since we've changed our technique to make the normal size glenoid, we have not had any hardware removal. We had little to no hardware irritation. There still is no instability from this. And what you actually see is these are the post-op glenoid CTs. About 6 years afterwards, you can see the supersized glenoids that we put in from before. This was a 13 millimeter graft, and because it remodeled, more screws stick out. But now in this case, where we actually used a normal size glenoid to template it with a remodeling, does not irritate anymore with those size screws. And still, after a significant period of time, so after 2 years of CT, the normal size anterior to posterior dimension is actually the same between both those groups. So this is how we know remodeling happens according to Wolff's Law, back to its normal shape. No matter what you do, trying to make a bigger size will not stay that way in a long-term process. This is an example of such a case. This is so on the left here, you can see the surgical time 1 surgery. And then on the right here is the 6-year outcome afterwards. And why we show you this is because all this anterior to the suture anchor where we did the Bankart repair is all new bone. And the new bone is not rectangular in shape anymore by looking at it, it's triangular. And it's no longer rectangular from this superior view or from the on-face view. It's now round. And in fact, it looks like a normal glenoid. And the only reason we did this was to remove the screws because they were too big. So tips and tricks, hopefully we'll show you. We can now reproducibly measure glenoid bone loss by measuring superior to inferior, so we don't have to confuse things. We can do a surgery that does not alter anatomy, does not require splitting of the subscap, so we can preserve the muscle by using the Halifax portal. And now we should recommend customizing the graft, since we better understand the remodeling of using allograft to have for patients with shoulder instability with bone loss. So this AAGR is as safe as a Bankart repair. We really do think so. We've done our cadaver study showing that going through the rotator interval are represented in green there. Because you leave subscap and conjoin, you're at least 4 centimeters away from neurovascular structures. You can see here in methylene blue, those structures are completely out of the way and you don't have to worry about hitting them. More importantly is now we've actually got our first 1 year early outcome randomized control trial to be able to show that AAGR is as safe as a Bankart repair, meaning no short-term outcome problems, and has less recurrence than a Bankart and normal recreation of glenoid diameter. So in these patients with subcritical bone loss, we're getting less redislocations, essentially no redislocations at the 1 year mark, whereas the Bankart soft tissue repair is still around 4 to 5% dislocation and subluxation mark. These patients are actually getting back to sport faster as well. In another study that we looked at a retrospective group to be able to show that recreating the bone, the patient's more stable and more happy to go back to their sport. And in fact, now using all this remote technology, just like PrecisionOS is going to show you, AAGR is able to be taught remotely. So this is great because we can get a refresher of the type of surgery closer to the time that a case is coming up. We can train other people that are in the surgery room, the PA, the assistant, the nursing, the OR team, and then allows for increased efficiency of an arthroscopic complex case, like a mini fellowship. So how we do something like that is we can do something like we're doing tonight, where there's a Zoom broadcast. And by using holograms and whatnot, it's like the surgeon eye view where you can actually recreate the whole idea, the planning of the surgery with the models like you're going to see on PrecisionOS. And then in the surgical room, we can actually use those multiple cameras to be able to guide where they are with holograms, so we can show you how we size it up, how we measure it, how we be able to cut it, and you can plan it to make sure you're away from all the neurovascular structures, all the difficulties from each of the cases coming through. And again, by having both those simultaneously broadcast, we can be able to guide to make sure that that flatness of the glenoid is nicely represented at the end of surgery. Then actually becomes even more exciting when we can flip it around to a virtual cadaver, where we can stay in separate locations, do a cadaveric course, where this is one of the surgeons that wants to do the AAGR procedure in a B-share position. We can overlay the drawings of where to put the anterior superior portal on their screen, and you can convey all this information real time to be able to get surgeons from around the world to be able to do the same surgery, having the same effects, to be able to learn how to do something like this. So hopefully we've gone through this to be able to show you that AAGR has the benefits of a bony reconstruction for decreasing recurrent instability like a Latarjet, but with the risk profile and ease of teaching like an arthroscopic Bankart. Thank you.
That's great, Ivan. Thank you so much. We're going to introduce a couple of poll questions. So Christine's going to put those up on the screen, and if people can answer them, we could talk a little bit about them while we're getting for the VR experience. So there's 3 questions here, and I'll read the questions out. Would you consider doing an arthroscopic bone block with DTA via Halifax portal? Yes or no? What concerns you most when considering doing an arthroscopic bone block via Halifax portal? And the third questions are what are the barriers do you have implementing this technology into your practice? So if people could answer those, we can talk about those while we're getting for VR. While the polls are coming up, Ivan, question for you is, are you more inclined to do this allograft reconstruction over a Bankart now? Or how do you indicate one over the other, especially in the condition of a subcritical bone loss?
Yeah, so this is the trouble, is where does subcritical stop, right? And honestly, when I can measure bone loss, I'll probably start putting bone in, which is really around 10%. But otherwise, if there's no bone loss, there's no point in doing something like this.
So we'll review the poll questions, Ivan, and perhaps you can comment on them while people are getting in. So the first one was, would you consider doing the DTA? 80% said yes. And perhaps we can bring these up as people get into VR. The second question is, what concerns you most about doing this via the Halifax portal? And number 1 was time required to learn. And number 2 was malpositioned graft. And the third question was, what are the barriers? Number 1 and 2 were cost and availability of training. So perhaps we can discuss those as we sort of break out into the VR session.
That's great. It's really nice to see at least that DTA at least is of discussion, because I'll tell you, just 5 years ago, wasn't even in a discussion at any of the conferences globally. So this is really exciting how fast things are actually changing to say that this is an option to go through. And all the things that you just finished discussing, including time to learn, these are definitely things, because all the focus has been on should we do something like this, and instead of how we teach something like this. And I think this is absolutely the next thing, which leads you to PrecisionOS, some technology like this to allow mass teaching of complex surgery to be able to do. This is critical to let something like this take off.
That's great. Thank you. And we'll pass over to you, Jay. You're live on PR.
Awesome. Thanks so much, Dr. Gold. We're excited to be here. So we are here with our two guest professors, Dr. Babhulkar and Dr. Nagda, and then Mike's running the camera as usual. And so the cool thing here is that, we've repurposed sort of this module, which is built to be a fracture module, into something that I think ends up lending itself really well to Latarjet and just coracoid transfer, bone transfer for shoulder instability. So we can sort of start getting going. I'd just like to kick it to our guest professors to talk about patient positioning and kind of pearls for maximizing success for visualization, screw fixation, and all of that.
Yeah, absolutely, Jay. Fortunately for the Latarjet, whether you do it open or arthroscopic, the bead chair works best. But the key for both these surgeries is the portals and the positioning. So a nice lazy bead chair and with the shoulder exposed without a support at the back. So you have complete 180-degree access to the shoulder, and ensure there's no tilt or kyphosis there. And that can be changed with keeping a sandbag behind, in between the scapulae. And then if you can draw the margins, and I would suggest draw the outer margins of the bone, because once the swelling comes up, the lines can change. So the outer margins are relevant. And as Jay has pointed out, this is a good representative of this left shoulder. And I would put my arthroscopy portals such that somebody can later come and merge them into an open incision.
Yep.
So my A portal is somewhere here, about 3 centimeters lateral to the coracoid, but a little bit away from the acromion. And then after that, I have to go in and draw the I portal, because unfortunately we don't have any hard bony landmark apart from the coracoid. So you have to be very particular here. So what I do is draw my D portal and my I portal, and then I'll position my E portal between these two. And then I would use my medial portal to be diametrically opposite here, in the same level as the E portal. This is very critical, because that is where the graph is going to come to, and that direction has to be in line with the plane of the scapula and the glenoid. Only then will your graph sit perfectly congruent to the anterior glenoid. And then the I portal is somewhere here, but a little superior and medial side. So if I wish to convert into an open because my arthroscopy is not going well, I can always convert my S portal and my A portal, or S portal and my E portal, to come in and convert to a open Latarjet.
Ashish, yes. That medial portal there, what are the landmarks for that portal right there?
So I think it's a very good question, because there are no fixed landmarks.
Right, yeah.
But that's why with trial and error, I've come to understand that if your E portal here is between the I and the D portal, then it is always in line with this. The whole idea is it has to be enough medial and inferior to be able to approach the inferior glenoid. And our tendency is to avoid going too medial. It's pretty safe as long as you know your landmarks. But if it is not, then you're going to struggle to bring your graft into a congruent position with the glenoid.
And I think if it's more kyphotic, you have to go even more medial, correct?
Absolutely, absolutely. And you can always, your assistant must be told that once the graft comes in, you're going to pull the shoulder behind, and in this manner, grab this shoulder and pull it behind to correct a little bit of that kyphosis.
That's great. And you could see, when you turn off the layers as well, sort of where some of those portals would have fallen. So obviously deep within the pec musculature.
Yes.
and then seeing the bones as well to reference. And we'll get even a better view once the K wires are in position and once the graft's in position.
Yeah.
Mike, do you also have the video? Do you want to start playing the first clip while we sort of keep going here? If next we can, what we can do is actually take this scapula out in space and look at the osteotomy that was made. So this was pre-made using the fracture lab that PrecisionOS has. I think that, one tool that's also nice is you can measure things. So we could see here that we have about 2.5, 2.7 centimeters of length. So that should be adequate for our graft. And so I'd be pretty happy with that intraoperatively.
Absolutely.
And so coming from here, another discussion is how should we position the graft, either traditional style like this or congruent arc style. So I'd love to get your guys' opinions on how you like to position the graft and how do you put it superior, inferior, as well as the position that it's in.
Yeah, I think that's a great point, Jay. Number one, working with Asian patients, our biggest struggle is the size of the coracoid. On an average, that tends to be about 24, 25 mm, which is still okay to accept 2 screws. Anything less than 20 mm is not on, then you have to consider Bristow. But if that coracoid is about 22, then your positioning of a guide wires is very critical. You have to be absolutely precise. If your first hole goes wrong, then the next hole will not be in line with the coracoid, or you'll fracture the end of the coracoid. And depending on whether you want to do a anatomical coracoid or you put it stand on for congruent arc Lataje. Now, unfortunately, most surgeons are fixed on, I would always do a congruent arc or I would always do an anatomical. But I think there's much more substance to this. If my bone loss is modest, of say 15%, then I think it makes sense in doing an anatomical because you don't want it too thick because it's just unnecessarily overstuffing that space. But when I'm dealing with a significant bone loss, 20, 25%, then I would prefer a congruent arc Lataje, and that gives me more bang for the buck. The only thing is it makes it a little bit more challenging. And the unfortunate thing is on arthroscopy, it's very difficult to do a congruent arc. So invariably, we are going to be stuck to doing a standard anatomical landmark. But Samir, what's your thought on that?
Yeah, I think you said it exactly right. I go case by case depending on the bone loss, but also if the loss is flattened right there and not a big hole, then I take the backside here and put anatomics. I can make it flat and put it flat right on there. So that's an important thing for me. The second thing is if the congruent arc side, if it's really narrow, I don't know if I can get 2 screws in there without maybe breaking it. Then I'll go the anatomical way as well. Those are the 2 things I take into consideration as to when I'll do one versus the other.
That's great.
Interesting thing about congruent arc is also the way the congruent arc is shaped. The surface of the medial surface of the coracoid matches the contour of the anterior glenoid. So if you have a modest bone loss, but you have a very round, then that's going to sit perfectly.
That's perfect. Yeah. But sometimes when you have that flattened glenoid, the inverted pair, the flat side of the back side just goes nice and just kind of sits right down.
Absolutely. Spot on. So there are many more things to consider before deciding anatomical or congruent arc.
Yep.
I guess that leads me to ask, can you oversize a free bone block graft? What are the sequelae of that? If you're taking either autograft or allograft, what have you seen as issues with, arthroscopic, I think introducing the graft becomes difficult, but maybe less so for open. Just curious, both of your thoughts.
Yes. I don't think it's a problem putting in a large feed bone graft because then we are not using the medial portal because on that way, let me try and work this out. Yeah. So then I would use the superior portal to introduce the graft through the rotator interval. And then we don't need this because we're not using the coracoid. So graft insertion is not a problem. But the problem is that when you're doing with extensive bone loss, especially in epileptics, the amount of osteolysis is going to be much more extensive for 2 reasons: that you overstuffed it, and based on Wolff's law, the body is going to accept only what it needs. And number 2, there's no tendon attached to that, so it's less vascular. So we traditionally see much more osteolysis with free bone grafts.
Yeah.
So if you need like a 10 mm width anterior posteriorly, you might as well put in a 12 so that you will get 8 or 9 out of that.
Yeah, I agree. The other thing I worry about some if it's too big, because the first time I did, I wanted to get as big as possible. And then I put in there, I'm like, I can't even get the subscap. It's going to hit on the subscap, so it's going to impinge
Yes.
on that. So that was the other thing. So I kind of whittled it down to make sure that it doesn't impinge on the subscap. That's the only other consideration for me.
Because you're right, Samir, that will impact the external rotation.
Yeah.
So if the graft is positioned higher, or if it's too large, then they lose external rotation.
Interesting. So it almost tensions the subscap just by virtue of the bulk of the graft.
Yeah, it tenses
That's right.
in the backside. Yeah.
Perfect. No, Mike, do we have the video? It's okay if not.
For the next. So then about your guide wire positioning, how can you elaborate on the tips and tricks on getting the correct? And of course, exposing the nerves, that's mandatory, right? Samir, do you do that for your open lateral J's? Exposing the musculocutaneous?
I do. I find them. I feel them with my fingers, so I know where they are, and I just kind of have it based on that. I don't actually go look for it. Once I take the coracoid down, I'll just kind of feel where it is, and I know where it is. And same with the axillary nerve. But I make sure I can feel it readily, both of them.
Yeah, even the axillary is frighteningly close to where we are, especially in the arthroscopy, where we put in our Wischinger rod from back to front. That rod will invariably hit the axillary nerve or begin right in line with that. So it's a good thing because that is going to protect the axillary nerve, but we need to know where the axillary nerve is because that's at risk.
Yeah, and you could see the proximity really well here. When you're trying to get access to the that coracoid graft, the anterior glenoid, the plexus is right there and axillary nerve's right under it. So we had a case in fellowship last year with Joe Aboud. He does intraoperative nerve monitoring.
Right.
And there was one case where when we secured the graft and compressed it down, we used that case was a Latarjet, and there was a little bit of decrease in the signals of the axillary nerve just when we tightened the screw. So we backed off and we repositioned the graft a little bit higher, and some of those signals came back, and the patient did great. But it was just interesting to see that live time feedback of maybe some pressure on the nerve from our graft position.
Yeah. Do you know how much he tolerates in terms of nerve loss? Because, if you get 10 or 20 or 30%, even up to 50%, it may not be clinically significant. But if you get an 80, 90% decrease, I think that's something you got to really kind of use it to make a change.
Yeah, exactly. It has to be 80, 90%, usually multiple heads of the deltoid or multiple muscles within a nerve group. Yeah. But yeah, then we can show wire trajectory. Mike, do you mind just hitting number 2? And since it's so much easier to place them with the scapula in total free space, I'm going to take advantage of that.
Yeah. You look like a rock star here.
Yeah, I wish you could do this in the real
I know, right?
situation.
So that's a little bit too close to the edge, but I'll leave it there for now.
Yeah.
This is nice because then we'll be able to see these wires outside the skin and their relationship to the rest of the shoulder once they're buried.
So what's your intention, Jay?
In this part here, what are you using to hold and secure the graft?
Just doing the open portion, I would like to use the K wires as like a joystick and position the graft and then provisionally fix and then drill my screw holes.
Yeah. And then Ashish, arthroscopically, how are you positioning it?
So arthroscopically, we would capture this graft on a blue cannula, and that has tubes that will capture the tubes, enter the holes, the same ones, and they're cannulated tubes. So once you've got the tubes in, because you've drilled them perfectly, I think half the job is done, and then just blindly fire the guide wires in. So that part is not such a big challenge in arthroscopy. The actual part is where these end up. If you can see here, this thing. So this position is very important. Number one, that your screws are not too long. And number two, they should be in the lower sector because we forget sometimes that there's a suprascapular nerve right here.
Exactly.
And the tendency in arthroscopy for these wires is to go high and medial, which is exactly heading into the suprascapular nerve area.
Mm-hmm.
So I have had to remove screws for a couple of patients. And the moment you remove the screws, they were pain-free and the movements improved and the infraspinatus started recruiting and kicking in. So that's something we need to be careful. So, which brings us to the point that how many of you use imaging during your surgery?
I don't, because I do it open. So,
Yeah,
usually
no,
I make sure I can feel the bottom of the glenoid. I make sure I'm right, not too low, because if you're too low and you start to hug the bottom, that's when you start to shoot them up, right? So I'm kind of making sure I'm between 3 o'clock and 6 o'clock there.
Yeah, no, same as well. Yeah, I mean, we'll see in a second what the fluoroscopy can sort of add in terms of screw trajectory, especially with difficult exposures, big athletic patients that, the exposure becomes more difficult. So it would be nice, but it's sort of the inconvenience that keeps it from being routine.
Yeah, on arthroscopy, it's impossible to keep the C-arm because there are too many monitors to watch. But when I'm doing an open Latarjet, I will always have a C-arm because I'm gutted when I see the next day that the screws are a little medial, a little off. But of course, you've got guides on arthroscopy which can ensure where they're hugging the articular side of the glenoid. So you can get your wires nice and parallel. So the idea is to keep the wires parallel in the lower sector and get a good alpha. So good alpha means that the wires are not too medial. They're in plane with the articular surface of the glenoid.
Yeah. I think
Dr.
the other thing is...
Yes. We have a question here from the chat.
Yes.
Question for Ashish. You're doing this in beach chair here. You showed us that. Any advantage of this over doing it in a lateral position?
So Grant, good question. But as far as I can see, the arthroscopic Latarjet cannot be done in the lateral position. There are several versions of it that can be done in the beach chair position. But if you really push to doing a coracoid graft, then one has to go, and you're committed to doing a lateral position, then you must use either the cerclage or the endo button type of Latarjets, where the surgeon comes from behind and then he's not going and exposing the axon nerve and going out of the box.
Got it. And so you're saying if you're going to find the nerves, you're saying that's not technically feasible in a lateral position?
Yes, because the musculocutaneous nerve is far too medial and inferior, and bringing a device to capture the coracoid from the front requires you to do that M portal, and then that's not possible. So, but if you approach and do all your fixation from behind, so it's like an indirect fixation without having to bring the screws from the front, then you have to choose one of those where your instrumentation is from posterior, like the cerclage or the endo buttons. You can do the coracoid osteotomy through the rotator interval, perhaps sometimes use a 70-degree scope, but you're not truly going out of the box.
Perfect. Very helpful. I'll continue to fire in questions. And for the audience, please feel free to put your questions in the chat and I will relay them to Dr. Nagda, Dr. Levin, and Dr. Babhulkar. Please continue. This is fabulous.
Yeah, I think one of the biggest things for me for arthroscopic, when you're doing it open, you want to make sure that the backside of it is flush and not angled off. So you have like it kind of, sitting at an angle and you're not getting good bone contact there. And I think arthroscopically, you have a much better chance to see that and make sure that it is flush on the bone there.
Smart. Absolutely agree, because the coracoid comes in all shapes and sizes.
Yep.
So I get very irritated when I see a very curved, short coracoid, which means that you have to continue doing a lot more preparation with your burr and grind it down. But the other tip is that in case you have a modest bone loss and your anterior glenoid is not in a straight line, then perhaps under-prepare a coracoid, because then you can have two curved surfaces matching each other.
Yeah.
Mike, do you want to play the video next?
And so this even shows, I think this model we discussed is probably more kyphotic than in real life, just given the position of the scapula on the chest wall. But you can see how medial, if you want perfect trajectory, how medial those sort of screws are exiting, in line.
Yeah, that's quite incredible, right?
Yeah. And so here we have the coracoid preparation.
So, Samir, between using a pre-iliac crest bone graft or a distal tibia versus a coracoid, what are the pros and cons of each?
Excuse, sorry, my headset just died. I had checked it the other day and it was fine, and now all of a sudden it's
Right,
dead.
right. Yeah, we'll fill in. You can come back in soon. So my understanding, Jay, is that because the coracoid itself is a bone graft, is giving you a structural support for anterior glenoid bone loss, the conjoint tendon also works like a very useful hammock to amplify the effects of a Latarjet. And that option doesn't exist with a pre-tibial bone graft or a iliac crest. So I think there's much more value addition. As Jody Bear used to say, the coracoid was designed for the Latarjet by God. Seriously. But sometimes you're dealing with incredible bone loss and the coracoid is not adequate enough to fill in. So that's when I'll go in for a free bone graft or iliac crest sometimes. Sometimes you're doing a revision Latarjet, so the coracoid is not available. But electively, if I have to choose an iliac crest bone graft, that would be in an epileptic patient who's non-compliant, in which case doing a Latarjet, I have two patients who had a seizure post-op, immediate post-op, because they stopped their meds, and they avulsed the complete coracoid because the conjoint was attached to that.
Okay.
So if I have an unreliable epileptic, then I would probably, firstly, I wouldn't operate them, but if you're compelled to, then it's much more logical to use a iliac crest bone graft because the graft will stay in place. It will not come off.
Okay. What are your thoughts in that setting to just make your coracoid osteotomy and reattach the conjoint to the base of the coracoid and use that graft still as a good local source of graft?
Right. Interesting, Jay, because if I have the coracoid and the conjoint, I'm absolutely keen to use both of them because there's value addition. I know patients who have had complete osteolysis of the coracoid, probably done when the bone loss was modest and the bone just disappeared. We removed the screws, but they still did not dislocate because the conjoint was working there as a hammer to amplify the subscap as a stabilizer.
Yeah, I agree. I think the conjoint tendon effect, I think, is really, some people, like me, agree that it is important, and others think it's not important, but I find it to be super helpful.
Absolutely.
Awesome. Yeah. I tell patients it's like a super labrum.
Exactly. And then
let's see.
Go on.
Ashish, about 10-minute warning for you all.
Yes. 10 minutes to go to the Kovalchuk? 10
minutes remaining for the webinar.
Right. We might as well go with the Kovalchuk then now, Jay, so that we can cover that as well. Let's change the patient so that we can complete the discussion. So we'll now move to the Kovalchuk procedure. And so, Jay, in comparison to the coracoid, how do you see the Kovalchuk osteotomy and the advantages?
Yeah, I mean, so I'm thinking of this more in, I know we could use the free transfer for anterior or posterior instability with related bone loss, but I think one of the powerful tools that we have with the posterior pediculated version with the deltoid attached is that you get somewhat of a sling effect from the deltoid as well, similar to the Latarjet. And I know Dr. Athwal's published on the biomechanics of this recently that there is probably an effect of that. So I think in those more dynamic cases of posterior instability, like revision posterior instability with bone loss, I think that becomes a more prominent option in my sort of workup or treatment.
Yeah, I agree. It's a good option because you're right there. You don't have to bring another graft in position. I've actually used the free bone graft sometimes when I'm stuck there and I didn't plan it well and I've gone in the scope and I've seen a bone loss. And then I can always access the iliac crest because probably the ICBG or the iliac crest was not draped and prepped.
Okay.
But I will use the iliacs, the spine of scapula only in subcritical bone loss. It is not enough to treat a conventional Latarjet type 15-20% glenoid bone loss. So if you're looking at a 10% bone loss and the labrum quality is poor, then that works as a much better augment to the poor quality labrum repair or revision Bankart cases.
That makes sense.
Similar to something what Ivan did. Ivan would do his bone block surgeries for 10% bone loss. Then rather than overstuff with a big coracoid graft, you could use a modest spine or scapula. Do you want
No,
to
that
show us
makes
When do you
any
guys
reason?
use distal clavicle?
So I've never used a distal clavicle because it's not the best quality bone. And again, if I were doing a subcritical bone loss where I don't really need a bone graft, but the labrum is of poor quality, then we need a Bankart plus procedure. So it's either using the distal clavicle, spine, or scapula. I actually bias towards doing a DAS procedure where I relocate the lunget of biceps and augment the labrum rather than use a bone graft for those 10% tree nut bone loss.
Yeah.
Yeah, I think I mean, it's probably, we don't probably clinically see it as much, but if in the setting of bad AC arthropathy and recurrent, instability, that could be a reason to do it if they may want a distal clavicle excision to treat their pain. But otherwise, no, I tend to
Nice
agree.
point. I like that perspective.
Yeah.
Yeah.
And there was one study, I think there was a study that found that like AC joint arthritis could be a risk factor as well for instability. Just
Right.
thinking about like stiffness at
Okay.
adjacent joints maybe can
Got it.
predispose to instability at the
Got it.
shoulder. But
Right.
yeah, this is
Jay, can you pull out the scapula so that the
oh yeah.
viewers can actually get to see the area where we're, yes. Yeah.
Yeah, so you were discussing, I mean, this as being sort of a low risk position to harvest relatively, like if we're taking it more laterally, high risk of
That's right.
fracture,
Right.
Yeah.
especially if we go bicortical with our harvest, and then
Yeah.
medially it's not sort of deep enough to harvest medially.
That's right. There's not much flesh on the bone medially, and so we're not going to get the deltoid pedicle, neither will we get the height. And this is probably the appropriate, Mike has prepared this beautifully. And going any more laterally will increase your fracture risk as well. You have to balance the ability to fill the pedicle and take it down. So if you're taking a pre-pedicle without a pedicle, just the bone graft, you can take it right there. But if you want to take the deltoid along with it, then you might want to come up here. But don't invade the base of the spine or the scapula, because that will be a real fracture risk. And then you want to swing down the pedicle and pass it to the posterior portal, and you want to put the graft there in. Can you pick up the graft position?
Oh yeah.
Yeah. And I would put it in there vertically, just in there. So this one is a tad little longer. You can always burr it down and make it to size, and as long as it's perfect there. And the strange thing I found, Jay, is that passing the guide wires and getting it parallel is much more easier for posterior instability than anterior instability. Because for anterior instability, you need to come in really far wide medially. Here, that's not such a problem. You just need to go a little bit more lateral, which is more ergonomic, more easy to do, and more replicable.
Yeah. And the same kyphosis that hurts us on the anterior side actually helps here.
That's right. You said it. But the funny thing is, yeah, go on.
Oh no, do you feel like it can usually accommodate the same fixation? It seems like it might be a little bit thinner in the sort of AP dimension typically, but do you still use the arthroscopic equipment to place these screws?
Yes. Yeah. Yes and no. The fun thing with the arthroscopy is that the blue cannula comes and sits in there. So if your blue cannula sat in there and the cannula guides are cannulated, so your guide wire is going to go in bang in between. So your prep has been done appropriately. You've seen that during that. If I find it's tenuous, then I'll just go open and put it there manually. But I will tell you, this is one case, posterior instability, where it's easier to do it arthroscopically because number one, we're not familiar with the posterior approach so well, and their muscles are very big. The planes are not so well defined like the deltopectoral, and the exposure is not as grand as you get with deltopectoral. So placing your guide wise is tedious because if you look here, the suprascapular nerve is right there. So you're very close to all the nerves and the axillary circumflex vessels. So that can be a problem. That's why arthroscopically is much more neater, better.
Oh, that's perfect.
And so then where's your camera angle? You're coming in from the front here on this one, right there?
Yes. So camera is in the anterior superior portal, as you would do for your posterior Bankart repair. So it's in the anterior superior portal. And then you've got two portals, one low to bring the graft in there, and the other to just tweak the portal like the Wilmington coming from here.
Yep.
And are you fixing labrum in the most labrum capsule over this in
Yes.
most settings? Yeah.
Yes. Yes. It's a rough bone. You don't want that to abut against the hyaline cartilage.
Yeah.
And number one, the labrum also provides proprioceptive input. And I think that is very important. So even in my arthrolatages, I would endeavor to try and fix the labrum between the graft and the native bone. So the strange thing about the Kovalchuk thing is the first paper was presented in France by Metai and Kovalchuk et al. And that's 2018, but that's just 6 cases. And I actually spoke to one of those authors, Jean Grumberg, who's my good friend. And he says that's just that many cases that are done. There are not many cases as such. So it's not very popular till George et al. Came and reinvented the wheel and then published it. So this was not something that was very familiar to all of us. So most of us would use a free Eilecher's graft instead of this.
That's amazing. And Dr. Babhulkar, we were talking yesterday, but I'd love to hear just your progression of, for people who are learning a new procedure like the arthroscopic Lohre, kind of how was your progression? How many cases did you feel like it took to get comfortable? It was really interesting to hear your process.
Well, Jay, I was hoping you wouldn't ask me that. The initial journey is very tedious. You need tremendous dollops of patience and relentless tenacity because this is a high focus group. You need to know the anatomy of the coracoid and out of the box, like the back of your hand. So initial cases took us 3 hours and such, but I would start for the first 10, 12 cases. I just did them on cadaver and then move them on the patient. I would just do arthroscopy, come out of the box, expose the coracoid, define all the lines, do the CA ligament resection, release the pec minor, and then just stop, convert to an open.
Yeah.
Until such time that I got my confidence in, understood how to make the portal. But till that time, you don't need to make the medial suicide portal. Once you get a confidence and you are able to create that space out of the box, that's when I would go and do an osteotomy and then leave it there and convert to open and do the fixation. And then at the third level, then do everything arthroscopic. And it requires a lot of teamwork. You need the best anesthetists because the blood pressure has to be well controlled. And you need lots of time on your hands. And then, so I think it takes about 30 to 50 cases, depending on your bio skills, to master it. But once you do, then it's very easy. It's not as bad as it is thought to be because it's a very precise. I think no other surgery has taken so much out of me as compared to the arthrolatagy.
Yeah, I think that was one of my issues was that, the learning curve is so long. And, in the US, I tend to do about 10 to 12 a year. So that would take me about, 3 to 4 years to get to that learning curve,
That's the point, yes. You need to do at least 40, 50 a year to be able to move on to the arthrolatagy because what you do today, you forget the next month.
Dr. Babhulkar, Dr. Nagda, Dr. Levin, a fabulous session. Let's come out of the VR environment and then we'll have 5 minutes in just the Zoom context to answer any questions. Again, for our audience, we really appreciate everyone joining,
Super.
whether you're in India and it's early Saturday morning or whether you're in North America and it's Friday evening. We really appreciate it. Any questions for our panelists tonight? That was an incredible review of a tour de force of how we do instability surgery by Ivan, Samir, Jay, and Ashish.
Grant, we're going to run a couple of quick polls while we have the
Let's do
audience.
it.
Christine,
Fire
if you
away.
have polls, and then we can. This is a very good topic to discuss. I'm sure we could talk for hours about it, but that was a very quick hour. So, Christine, if you want to run those polls. So here's the first question. Would people in the audience be interested in a one-on-one virtual reality session with a shoulder elbow expert? So you could be anywhere in the world, and while people are thinking about this question, just to set the stage, everybody that was in the virtual environment are in completely different parts of the world. So Dr. Babhulkar is in India, Dr. Nagda is in Northern Virginia, and Dr. Levin's in Durham, North Carolina. So from all over the world, we brought people together, which is fascinating.
It changes the metric, right, Danny? There are no boundaries now.
No.
And so if somebody wants to pick up a distal tibia or understand the technique of Ivan Wong and the Halifax portal, they can approach him. And then I think Ivan does a lot of these virtual webinars and training sessions online. Ivan would be the best person to comment on this.
Oh yeah, no, this has been great. We've been doing this 3, 4 times a week, so it's wonderful. And I do think having avenues like this to be able to get everyone into the same virtual room with that 3D drawing on top, this is fantastic.
So just on that poll, there was an overwhelming yes with 95% of the recipients saying yes. So let's run the next poll if we can. While we're pulling that up, Ivan, maybe you could speak a little bit about the question about lateral versus beach chair, because I know there's some debate as to what's, I guess, a surgeon preference, but why don't you discuss your preference on that?
Yeah, no, that's great. Ashish is a phenomenal surgeon, and I went to go learn I went through my journey of arthroscopic lateral J over a decade ago. I'm a lateral diffuse surgeon, so again, I came back, I tried to do a beach chair, I just can't get my head around it. So we developed our technique to do it lateral. We've published it in Arthroscopic Techniques for anyone who wants to do an arthroscopic lateral J lateral. It is definitely possible. There's different tips and tricks to do. No problem. We've done 30, 40 of them, but since we've done the distal tibia bone block, we really haven't turned back because it's so much easier, safer, and reproducible and quicker.
In the lateral position, huh? That's great.
Yeah, in lateral. So anyone who wanted it, I know lots of surgeons flew up here to learn lateral. I realized that it's not a heavy hitter and it's so complex that we didn't have any surgeons that took it up afterwards. So again, there's not many people that do it that way.
So for people interested, while we're pulling up the next poll question, for anybody interested in learning more about this application that was used by the surgeons, I put a link in the chat for those who are interested to learn more about the fracture lab. There's a question in the chat for the group. Any difference in graft healing in allograft versus autograft? Maybe I'll start with you, Ashish.
For the arthroscopic, there is a difference because the coracoid is intact. So then your medial axis is rather limited. So I would bring my free bone graft through the rotator interval. And that's not such a big challenge, but you need either a 10 mm cannula or you can dilate that with your finger and introduce your bone graft from the rotator interval down, which means that you need to prepare your glenoid and ensure that the labrum is not in blocking the access for the graft. And then you proceed to doing the same technique across, not a problem. We have no problem passing in a graft of 25 by 10 mm, and that still works through. And that way you spare the conjoint tendon and the coracoid, and then you don't need to bother about the musculocutaneous nerve or the medial porta.
Right. So this the question that came in was do people do the allograft reconstruction using DTA? But 33% said yes, and 67% said no. So lots of growth opportunity there for people to learn that technique. So we're at 7. Grant, shall we wrap up? I know that hour went by really quickly.
Yeah.
I mean, incredibly quickly, but I mean, we did cover an incredible amount of ground there. So I think we have to wrap it up. They always say leave them wanting more, and I know I'm definitely wanting to hear more of this conversation. So hopefully we'll have another command repeat performance from Ashish, Ivan, Jay, and Samir, and your team, you and your team, Danny. So thank you to PrecisionOS for the partnership with ASES. Thanks to Ashish from joining us all the way from India. Thanks to all the Indian surgeons that are members of the Indian Shoulder Society for joining us. And thanks to Samir, who really is a founder in kind of some of the Indian American Shoulder Society, ASCS, and the Indian Shoulder Society bringing us all together. So really a fabulous time. I think there'll be some recording available at some point in the future, and we look forward to more international events with PrecisionOS. Thank you all. Have a great weekend.
Thank you, everyone. Thanks for inviting me.
Thank you, everybody.
Yeah, thank you all.